Hola a todos, hola a
Hello,
todos.
everyone. Good morning. Thank you very much for joining us on this press briefing of the Pan American Health Organization on the COVID-19 pandemic in the region of the Americas today, Wednesday, February 3rd, 2021. And I'm Sebastian Ollier from the Communication Department of PAHO. And this session, as every week, will be around 45 minutes to 1 hour, and we will be taking questions up until that point. We have received questions from all of you by email, and you will have the opportunity to ask questions live and through the chat, through the Q&A button. Remember always to include your name and your communication medium that you represent. We have simultaneous interpretation into English and to Spanish. And today we have also interpretation into French and into Portuguese. So you can click on the interpretation button. Today, the director of PAHO, Dr. Carissa Etienne, will talk about the current situation of the pandemic in the region of the Americas, and she will go deeper into gender issues because the virus is affecting women and men in different ways. Dr. Etienne will be accompanied by Dr. Jarbas Barbosa, Assistant Director of PAHO, Dr. Ciro Gard, the Director of Health Emergencies of PAHO, and Dr. Silvana Aldegueri, Incident Manager for COVID-19 from PAHO as well. I would like to invite Dr. Etienne to share with us her introductory
Thank you,
remarks. Dr. Etienne.
Sebastian. And good morning. And thank you for joining today's press briefing. Last week, over 1.8 million people in the Americas became sick with COVID-19, and more than 47,000 died as a result. It's extraordinary that this time last year, the first cases of COVID-19 were being reported in Latin America. 12 months later, the virus has left no country untouched. In North America, after weeks of unrelenting rise, COVID-19 infections are finally decreasing in the United States and Canada. While in Mexico, cases and deaths continue to increase, particularly in the states that attracted significant tourism during the holiday season, like Guerrero, Quintana Roo, Nayarit, and Baja California del Sur. In Central America, Guatemala and Honduras are continuing to report a rise in COVID-19 infections. Across the Caribbean, most nations are seeing a reprieve in COVID-19 infections, although larger islands like the Dominican Republic, Haiti, Puerto Rico, and Cuba continue to drive new infections. This week, St. Lucia and Barbados reported the highest increase in cases. And as a result, St. Lucia has implemented a 10-day ban on non-essential activities and social gatherings. Nearly every country in South America has reported a rise in COVID-19 infections over the last week. Colombia continues to report the highest incidence in cases, followed by Brazil, which is still seeing exponential increases in both cases and deaths in the city of Manaus. Today, we're seeing that cities, provinces, and countries that had previously managed to control COVID-19 outbreaks are seeing a sometimes devastating resurgence in cases in our region and beyond. This should serve as a lesson that keeping the virus at bay is not a one-time effort, but a constant commitment while transmission is still active. And this is especially true as three new variants of concern of SARS-CoV-2 virus, which are raising questions about possible heightened transmissibility of COVID-19, have been detected in 20 countries in the Americas. However, their frequency is still limited. We know that might change over a few weeks or months. While any one of us could become infected with the virus, we've seen time and again how the virus preys on persistent inequalities in access to healthcare and across gender, race, and income divides. So today I would like to dive deeper into the gender dimensions of this pandemic because this virus is impacted men and women differently. Early in the pandemic, we saw that men were more likely to become sick with COVID-19. There were many reasons for this. Men were more likely to hold jobs that left them exposed to the virus and more likely to suffer from underlying conditions like diabetes and hypertension that made them more susceptible to severe COVID infections. As with other diseases, men often delay seeking help, leaving them more vulnerable to serious COVID illness that required hospitalizations. Today, some of these trends are reversing. Across every age group, men and women are just as likely to become infected with COVID-19. Women, who make up 70% of the world's health workers, have faced enormous personal risk to care for COVID patients, even when they had little protective equipment at their disposal. The women who staff nursing homes, daycare centers, and grocery stores have been on the front lines of this virus as they cared for our elderly, educated our children, and continued to work so we all had food to eat and to feed our families. Pregnant women whose immune systems change throughout the course of their pregnancy are more susceptible to respiratory infections like COVID-19, and especially if they're older, overweight, or have existing medical conditions. Ironically, as countries began reporting COVID-19 outbreaks, maternal, newborn, and child services were often the first to be suspended as healthcare workers were reassigned to the pandemic response and the clinics were repurposed to care for COVID patients. Beyond the unique health risks that women face with COVID-19, women are also disproportionately affected by the social and economic impacts of this virus. Women are invariably caretakers across our region. And as schools closed and lockdowns were imposed, the burden of care has fallen on mothers and grandmothers alike. Many women have been forced to leave their jobs to care for their families during this pandemic, impacting both their income and their well-being. And the ongoing stay-at-home measures, coupled with the added economic strains, are increasing the risk of domestic violence. For too many women, home is not a safe space. The pandemic is exacerbating gender inequities. And to overcome this pandemic, countries must recognize and respond to the gender dynamics of this outbreak. This starts with ensuring that women and girls can access the health services that they need, especially during this time of crisis. This includes gender violence hotlines and sexual and reproductive health services, which are essential services. By leveraging telehealth, leaning on community health workers, and making care available outside of hospital settings, health systems can ensure that women receive the care that they deserve. As limited COVID-19 vaccines arrive across our region, countries must also prioritize these early doses for our elderly and our health workers, many of whom are women. Vaccinating health workers first is both the right and the smart thing to do. It will help us save lives, protect our health systems, and recover our economies faster. And as we recover and rebuild from this global crisis, we urge countries to develop policies not for women, but by women, with the full involvement of women, by employing women in their pandemic planning and placing them at the very center of recovery. Women are some of our most powerful leaders, our leading scientists, our best health workers, and our most effective communicators. And we need their help to ensure that communities are adequately supported and prepared as we begin immunization campaigns. Across the Americas, women are more likely than men to live in poverty, more likely to face unpaid work, and less likely to participate in our economies. And this pandemic threatens to widen this divide. For many countries, the pandemic has served as an inflection point as they consider how their health, economic, and social policies shaped their pandemic response. We hope that countries seize this opportunity to address the pervasive gender inequalities across our region and ensure that men and women can lead healthy and productive lives. Before wrapping up today, I also want to recognize that tomorrow is World Cancer Day. Cancer is the second leading cause of death in the Americas. Unlike COVID-19, cancer is a disease that exacerbates inequalities. Those who live in poverty with limited access to healthcare are especially at risk. And yet, about a third of all cancer cases are preventable with, among other things, good diet, exercise, and timely screening. So as we talk about the urgency of building back better from this pandemic, we are reminded that we must ensure that our health systems can adequately care for patients who are battling COVID-19, but can provide support for the millions of patients living with conditions like diabetes, hypertension, and of course, cancer. Over, Sebastian.
Muchas gracias, doctora Etienne. Vamos a pasar ahora.
Thank you, Dr. Etienne. Now we will go now to the Q&A, and I remind you that you can ask your questions through the Q&A button and include your name and media. And today we have simultaneous interpretation to English, Spanish, French, and Portuguese. We have several questions, and we continue to hear some questions about vaccines. Teresa Welsh, the Devils, and Manuel Andreoni from New York Times in Brazil, with Nicholas, with the equitable distribution of the vaccines. The questions are:
COVID vaccinations in the region. How is PAHO working with governments and other organizations to ensure equal access to the vaccine? Doctora Etienne.
Thank you very much for this question.
Muchas gracias por esta pregunta, la cual es una pregunta muy importante. Nuestra región, ustedes saben, tiene que inmunizar a muchas personas contra el COVID-19. Ya han empezado 6 países y territorios que están participando en COVAX, recibieron notificación de que más de 35 millones de dosis de la vacuna de AstraZeneca empezarán a llegar a fines de febrero. COVAX ha liberado un pronóstico de cuántas dosis de las distintas vacunas podrían ponerse a disposición para cada país este año. Recuerden ustedes que el suministro de vacunas aumentará de manera constante con 218 millones de dosis de vacunas que se espera llegarán en las Américas y en el Caribe para fines de 2021. AstraZeneca y Pfizer tienen sus vacunas que empezarán a llegar en el mes de febrero, con otras vacunas, incluyendo Novavax y Johnson, también tienen vacunas que empezarán a llegar más o menos en el mes de abril de 2021. Y este papel, como lo ha dicho siempre COVAX, es dar vacunas para por lo menos el 20% de la población en cada país que esté participando en el mecanismo COVAX, con el fin de proteger a quienes están más a riesgo de las formas severas de COVID-19. El estado de la entrega de las vacunas, creo, es un paso que nos da esperanza en la lucha contra este virus. La OPS está orgullosa de facilitar un esfuerzo que se necesita de manera urgente en nuestra región. El Fondo Rotatorio de Vacunas en la OPS está conduciendo esfuerzos para dar dosis de vacunas de COVID a nombre del mecanismo COVAX para los países de las Américas. Pero si bien las vacunas empezarán a llegar pronto, es muy importante recalcar que las dosis de las vacunas son limitadas y seguirán siendo limitadas en todas partes, por lo menos en un comienzo, pero estamos trabajando con denuedo para asegurarnos de que los países estén listos cuando las vacunas también estén listas para llegar y para que se desplieguen apropiadamente. Creo que tenemos un testimonio de nuestra solidaridad regional y del valor de la colaboración. Nuestra primera prioridad es salvar vidas y por lo tanto el primer despliegue de vacunas irá a quienes son los más vulnerables, como los trabajadores sanitarios y las personas de edad que tienen más riesgo. Y esto es lo correcto de hacer y lo inteligente de hacer, porque apalancamos las pocas dosis que tenemos inicialmente para que tengan el mayor impacto, previniendo hospitalizaciones y muertes, protegiendo a los trabajadores de la salud y reduciendo el estrés sobre nuestro sistema sanitario. Debemos recalcar, sin embargo, que el acceso a las vacunas contra COVID-19 no debe ser un privilegio para unos pocos, sino un derecho que todos compartimos independientemente de quiénes seamos o dónde vivamos o de dónde vengamos. La vacunación para todos es nuestro objetivo final y la OPS está trabajando con COVAX, con nuestros donantes, con Estados miembros para realizar esta visión. Por lo tanto, los países de nuestra región deberían empezar a esperar recibir las vacunas de COVAX pronto. Algunos ya tienen vacunas que han obtenido por acuerdos bilaterales y la OPS seguirá apoyando a todos los Estados miembros para asegurarse de que estén listos y preparados con base en una experiencia ya de muchos años por las campañas de vacunación que hemos tenido en la región. Gracias.
Preguntas. Les pedimos disculpas que hay algunos
Thank you, Dr. Etienne. There are some technical problems with the interpretation. We have a question from Milagros Berrios from the La República in Peru. Milagros, if you are listening to us, you have the floor for your question. Yes, good morning. Thank you very much. Regarding the latest reports about the distribution of vaccines from COVAX, it was reported to us that 4 countries, among them Peru, would be the first in Latin America to receive a first lot of COVAX in the first quarter of this year. In the case of Peru, could you please tell us a tentative date or confirm when this first lot would be AstraZeneca or Pfizer and who would be in charge of sending it? And we would like to know why these first 4 countries have been chosen. Thank you very much, Milagros, Dr. Barbosa. Thank you. Thank you very much for your question, Milagros. All countries who are participating in COVAX, 190 countries, they received an official letter on Friday evening from the COVAX facility with information about the estimate for delivery starting from the end of February for the first quarter, all countries have know the amount of vaccines they will be receiving during that period. And we have the 8 countries that are going to be receiving a first special delivery. This first special delivery, and Peru is one of the 4 countries that are going to be receiving this first delivery, Colombia, El Salvador, and Bolivia being the other 3. And these results of the first delivery from Pfizer vaccines, Pfizer has a contract for 40 million doses, but this is 1.2 million doses only. And the countries were selected first, those who wanted to participate, because some countries did not want to participate because they didn't have the ability or the capacity to store the Pfizer vaccine. But out of the countries that reported they wanted to participate, there was an evaluation of their capacity in the Americas. All countries that wanted to participate were ready to receive, and countries that already had vaccines through bilateral agreements who already were using the vaccine. And then there was a risk criteria, which was the mortality rate in the last 28 days. This was taken as an approximation, a proxy of the risk of transmission for health workers. So 2 countries in the Americas who are part of the countries that will be receiving support from COVAX, and these are Bolivia and El Salvador, and 2 countries that are part of COVAX who are high financing countries, and these are Peru and Colombia. This first delivery will happen within 1 to 2 weeks. Countries need to make certain provisions. They have to sign the contract, etc. The next shipments will be um, sent as normally through COVAX, and they will begin with AstraZeneca vaccines. There are 2 places where it's being manufactured in Korea by South Korea Bioscience, and there is the Serum Institute from India, and that one is still pending to receive the emergency use authorization from WHO. But the revolving fund is the facility to purchase from COVAX for the countries of the Americas. So we are in negotiations with all the manufacturers. The logistics is not easy. It's a complex logistics, but we will be sending for each country when we have an exact date, and we will tell them the exact amount. But they know that there is some amount for the first half of the year, and countries will be able to make their necessary changes to their vaccination plans in their countries. Thank you. Thank you, Doctor. Next question is from Mariana Sofia Garcia from Coronica Uno in Venezuela. Mariana, if you're listening to us, over to you.
A ver ahora.
Let's see. Yes, hello. Sebastian, I wanted to know whether you can tell us something about the access of Venezuela to the COVAX facility and for receiving doses, and if and when would be when would we receiving them to have the population prepared? Thank you, Mariana. Dr. Barbosa, over to you. Thank you for your question. Before I can answer that, I wanted to supplement the question by Milagros. I don't know if you have the amounts already, but for Peru in particular, it's 1,653,000 doses for the AstraZeneca for COVAX. And this first, you will be receiving 170,000 from Pfizer vaccines. And Now, I will share with my colleague Ciro Ugarte for Venezuela. There is an amount assigned for Venezuela, 425,000 vaccines from AstraZeneca. All these estimates for the countries agree with the objective of an equitable distribution. And so during the first phase of COVAC, we will cover at least 3% of the population, corresponding to a sufficient amount to protect those who are the most vulnerable, who are health workers on the one hand, and other social workers who are in the front line. So Venezuela is part of COVAX. They already have some vaccine that has been allotted or reserved, and so that they can receive the vaccine. But there are still some issues regarding the payment of because Venezuela is a country of high financing. I now turn it over to Ciro Ugarte, who can supplement my reply. Thank you, Jarvis. Yes, effectively, this is good news. And it is also supplemented by the willingness of the parties in Venezuela. President Maduro announced his willingness to achieve access to vaccines through the COVAX facility, but also from other sources. And likewise, the Guaido group has expressed their intention as well. And many other actors from the international community are working hard to achieve a situation where Venezuela can have access to the vaccines. And these steps, of course, require more discussion, more agreements, and more facilities. And I think we are uh, uh, on the right path, and we if we can all put of our part to continue in our negotiations, it will benefit both the Venezuelan population inside Venezuela and outside Venezuela. Thank you both for your answers regarding Venezuela. In the same sense, I hope well, we have hopefully answered the questions from Ms. Nunez and Mariana Soquet and others who have asked questions about vaccines and Venezuela. The other questions that are related to oxygen in the region from Matthew Perrault from the La Prensa Canada wanted to hear more about the interventions of PAHO in Manaus, Brazil, and they wanted to know whether it's a crisis of oxygen, how much oxygen has PAHO sent to the region, and what recommendations are given to the countries. Dr. Alighieri, over to you.
Thank you very much for that question. This is a very important component of the response that has to do with oxygen provision. And I don't think that we can talk about a crisis in connection with oxygen. Some countries in the region, in particular Andean countries, to be more specific, of the last year in Brazil, in Manaus, of the last couple of weeks, have had a very significant impact in terms of the arrival of patients who have complications or critical patients, and those patients have required oxygen. The local production capacity for oxygen in some cases has not been sufficient to supply the health units, the hospitals, and that has had a domino effect, as we have seen in different news channels, and families are desperately looking for oxygen in the market for patients within their own families. First, I would like to refer to the guidelines in connection with patient management. PAHO has published and is updating very specific guidelines for the clinical management of patients, whatever is required, and when oxygen should be administered throughout the flow of management, from the detection of low oxygen levels, thanks to the use of oximeters based on the guidelines for clinical management of COVID, up to the amount of oxygen to be used in patients that have complications. But the guidelines on clinical management of patients have to be framed in a response operation that includes all of the stages within supply, from the production up to the arrival to the health unit, and also to monitor ahead of time access to oxygen to avoid any gaps. Some countries have faced very important challenges over the last couple of months. In extreme situations, PAHO did need to support local governments, such as in the case of Manaus in the Amazon state, to send supplementary amounts of oxygen, medical grade oxygen produced in other areas or in other states of the country. An important aspect of our work is to guarantee that the patient may work through the various levels of healthcare and the use of oxygen extraction equipment that can be used in the health units as in a way to anticipate this type of problems. PAHO has donated more than 600 extraction units to various countries, and in some cases, PAHO has also supported the local development of oxygen in remote areas or areas that are difficult to access, and this has to do with a project in the Guajira in Colombia that has been supported by PAHO. I hope I framed my answer in the complexity of this crisis management. Thank you. Thank you very much. The next question is by Steven Cyrilian. Steven?
Steven Cyrilian from PGD2 in St. Martin.
Thank you so very much. My question is for the director of PAHO, Dr. Etienne, if I may. The Pan American Health Organization said that the COVID global vaccine sharing scheme expects to deliver over 35 million doses of the AstraZeneca's COVID-19 vaccine to 17 Caribbean and 15 Latin American nations between mid-February and the end of June. What is the criterion used by PAHO in making COVID-19 vaccines available to the Caribbean countries in particular, Doctor?
Muchas gracias, Steven. Doctor Barbosa, que es nuestro...
Thank you very much for your question. Our expert on COVAX within the organization, Dr. Barbosa, will address this question.
The same for all the countries participating in COVAX. This decision was made by COVAX governance. COVAX governance is, we have countries that participate in these decisions. We have also WTO, we have CEPI and Gavi that are participating of COVAX. PAHO's revolving fund with UNICEF are the mechanism that will purchase the vaccine, but the allocation is not made by PAHO alone. The allocation of vaccines is made in a global perspective. COVAX has established an independent committee of experts that are making the proposal, and this proposal are analyzed by Gavi, by CEPI, by WTO, and by the countries that are participating in this governance. For this first announcement that was made, we have only the vaccines from AstraZeneca, both the two sites that are producing the AstraZeneca vaccine, in South Korea, and in India. We are also expecting that we will finalize the agreement with Pfizer to have the full 40 million doses to be deployed in the first semester too, but we are still finalizing the contract. So the distribution of these vaccines was made trying to reach at least 3% of the population, the average of all the countries in the Caribbean, in South America, in Central America, in Africa, in Asia, in all the regions. The average is that they will receive 3.3% of their population. And this will be, I think, that an important accomplishment, because this will allow these countries to vaccinate the most vulnerable population, health workers, and other social workers in the front line. Thank you.
Muchas gracias, doctor. La siguiente pregunta
Thank you
viene...
very much, Dr. Barbosa. The next question is from 505 in Nicaragua. They are saying that in the case of Nicaragua, they have seen that the vaccine to be received through COVAX will be the AstraZeneca vaccine, but this has no efficacy data on adults older than 65, and this would be preventing or undermining the goal to vaccinate this group of people. So what is the recommendation from PAHO to vaccinate with this vaccine? What are the conditions that the country should have to receive these vaccines? And also, what is the plan presented by Nicaragua to PAHO for vaccination? Thank you very much for your question. For the vaccines to be purchased through COVAX, the revolving fund with PAHO and UNICEF will only be acquiring vaccines that have been pre-qualified for use in emergencies according to WHO. Pfizer's vaccine has already been authorized. It is ready for deployment. AstraZeneca's vaccine has not been delivered because we're still working on the final reviews, and we understand that we will be finishing this within 1 or 2 weeks. Some regulatory authorities considered that the data for people older than 65 were not enough, but a regulatory agency in Europe, EMA, that is one of the rigorous authorities working with WHO, thought that the data could allow us to vaccinate people older than 65. What are we going to do once we conclude the analysis within WHO? And if the authorization for emergency use was granted, the group of experts within WHO will issue that recommendation. So we already have that recommendation for Pfizer's vaccine, and within a couple of weeks, we're going to have this for AstraZeneca's vaccine. So all of the countries will be receiving all of the technical guidelines, and also within our region, we have a technical group, experts on vaccination, that advise the organization, and all of the countries will be receiving all of the technical information, how to use the vaccine, whether it has any side effects, whether other vaccines could be used, and all of this information will be sent to the countries for them to use within their national immunization plans. So the countries need to conclude their preparation to verify all of the aspects in their plans, whether human resources are trained, whether the cold chain is effective, whether communication with individuals is ready, whether the administrative and legal aspects are also adequate, for example, the different clauses to be signed and accepted by the countries. All that is the type of work that has to be done by the countries, and prior to delivering the vaccine, there will be detailed information on the use of the vaccine that will be provided to the countries, and all of the vaccines will be pre-qualified or authorized for emergency use by WHO. Thank you. The next question comes from Terence McCoy from the Brazilian newspaper.
Tratamiento precoce or a litany of unproven medications, hydroxychloroquine, azithromycin, ivermectin, to curb the onset of serious symptoms of the coronavirus. Despite the lack of evidence, the Ministry of Health continues to promote these medications. I am hoping to understand the global context on this issue. Is Brazil an outlier of these medications? Are there other countries in the region or the world that are also actively promoting such medications? Dr. Aldiguieri?
Thank you for these questions. Thank you to the colleague based in Brazil. Regarding it, after 1 year of evolution of the pandemic, it's quite surprising to see this litany, as you said, of unproven medications, mainly with repurposed molecules, hydroxychloroquine, azithromycin, etc. I would say it's also still a challenge, as highly precise and updated information is available to the medical community and also to the public. Another challenge is also to have the public this notion of strong evidence versus weak evidence. What are we recommended or not recommending? And the notion of not recommending versus recommending against the use of a specific molecule. So at this, taking advantage of this question, I'd like to make a call to the medical and scientific societies to play a stronger role and to review evidence together with the ministries of health to update the guidelines using available information. WHO has just updated its clinical management guidelines during the last week of January. PAHO is updating on a regular basis, minimum twice per month, its systematic review of potential therapeutics. And this review use a well-proven methodology, which is a great methodology, and that would allow the doctors and scientists to access information already classified by the level of evidence. So it's still challenging. You have a special point regarding Brazil. Brazil is not alone in this region. There are many countries of the region still with this late assimilation of the scientific evidence at this moment. And the region, Latin America, is not alone. Also in other continents, including in Europe, there are still this unproven medication, the litany of unproven medications that are still circulating among the professional networks at this moment, unfortunately. Over.
Gracias, doctor. Tenemos dos preguntas.
Thank you very much, doctor. We have two similar questions related to AstraZeneca's vaccine. Jacqueline Charles from Miami Herald and Nadine Wilson Harris from the Clear in Jamaica. Jacqueline Charles says,
about the efficacy of AstraZeneca, how confident are we about it, and why only a few countries are getting Pfizer? And Nadine Wilson Harris from the Gleaner asks, health experts in some countries have cautioned against giving the vaccines to persons over 65, especially the AstraZeneca. What is PAHO's view on this, especially as it relates to giving vaccines to those who are frail? Dr. Barbosa?
Thank you for these two important questions. First, we can only say something about the vaccine, not only AstraZeneca, but all the vaccines. And all vaccines are welcome to COVAX, but we can only say something about this vaccine after the conclusion of the assessment, and it's a very thoroughly assessment that the pre-qualification team in WHO Geneva is performing just now. We have some health regulatory authorities, some of the stringent health regulatory authorities have already approved AstraZeneca use, such as the European agency, EMA, but we are still pending this assessment. We do believe that in 1-2 weeks, max, we will have this assessment. Second, let's think that when we are talking about vaccine, we are talking about the two different and complementary effects. The first one is the individual protection, and it's important that everyone that gets vaccinated will be protected against the transmission. But we are also talking about the collective protection that a vaccine is producing. So there was, from the beginning, some mathematical models showing that we can use any vaccine that has more than 50% of efficacy rate, because these vaccines, if we reach a high vaccine coverage, they will protect and they will be efficient to control the transmission. So this was the threshold that was established. Of course, that we want to have higher efficacy rate, but even with a vaccine that has 55 or 60, 65, 70, 75, we can reach a collective protection if we can get a very high immunization coverage. So for this reason, it's very important that the Ministry of Health, the health authorities, need to communicate in a very transparent way to people about the safety and the efficacy of the vaccines, to establish their national plans to get the people that need to be vaccinated really getting this vaccine. And the vaccine will not work alone. We need to keep all the non-pharmaceutical measures, both at the individual and the collective level, that we know that it can work, that it can protect the infection. To wear masks, to keep the physical distance, to avoid crowded enclosed spaces, washing hands, and all the other measures that will work with the vaccine to control the transmission in the near future. Thank you.
Gracias, doctor. Tenemos todavía varias preguntas vinculadas.
Thank you very much, Doctor. We still have several questions in connection with COVAX and the vaccines. Ileana Cornejo from El Salvador is asking Dr. Barbosa, when in your previous answer, you said that you took into account the mortality rate over the last 28 days in those countries that will be receiving the vaccines. And what did you mean that El Salvador, for example, has a high rate of mortality? Well, we have several criteria. We have a limited number of vaccines from Pfizer, a little bit over 1 million. And within COVAX, we would like to have equitable access. So we are, throughout our discussion, we were trying to identify the countries that wanted to participate. First, we looked at the criteria and whether the country is ready to receive the vaccine, whether they have the capability for cold chain, for a vaccine that requires minus 75 degrees for its preservation. All of the countries in the Americas did have the capacity, and those countries that indicated that wanted to be part of that special delivery. And then we also looked into the countries that do not have bilateral agreements, that have no access to vaccines. That is also important to maintain equitable access. And then we thought about distribution throughout the 6 regions that WHO has. So we wanted to take distribution into account, and finally to see what countries would be receiving support. The 10 countries in our region, 92 countries in the world that will be receiving the vaccines without the need to pay due to donations and the countries that will be paying, that is to say, the self-financing countries. Given that list, at the end, we used a risk criterion and how to measure risk in those situations. We took the mortality rate over the last 28 days, that is to say, the most recent mortality rate, because if the mortality rate is high, that signals that the risk is higher in those countries for health professionals. And health professionals would be the target audience of this special delivery. So in this region, we see the countries that will be receiving the vaccine without the need of for any payment. Bolivia, that has a mortality rate of 7.6%. El Salvador, that has 3.99% every per 100,000 inhabitants in terms of mortality rate. And for self-financing risk, we have Colombia, that has an 8% mortality rate, and Peru, that has 6.98% mortality per 100,000 inhabitants. So those two countries that are self-financed are the ones that were chosen, but you need to remember that the first criterion was to determine whether they are ready, whether they have a vaccination plan schedule, and whether they can deliver the vaccine. And it was very important in the region of the Americas to have the highest number of countries within the regions that were considered ready to administer the vaccines. We know that we have a lot to do to be ready to deliver the vaccine, but our region does have experience with immunization and leadership in this area, and we do have countries that have made incredible progress and that are ready to properly vaccinate. Thank you very much, Doctor. We have more questions on vaccines. This is Vivian Sequeira from Reuters in Caracas and Mariana from Venezuela. And based on what was said before, they're asking whether Venezuela can have or be granted a deadline to receive the vaccines if Venezuela is unable to pay by February 9th. And then Mariana Soquet is asking whether we know the amount of money to be paid by Venezuela to have access to the vaccines through COVAX. Dr. Barbosa. Thank you. First of all, Venezuela and all of the countries need to pay based on an estimate of $10 a dose, because the price range is quite different. We have vaccines that cost $3 and others that cost $30. So we average out the amounts and we establish about $10 a dose. And each country, by thinking of the number of doses requested, for example, if they requested vaccines for 20% of their population, they would have to pay an advance of 15%. This is something that was done by all of the countries. There are some changes because some countries requested coverage for 10%, others for 20%, and others for 30% of their population. But that is the idea. That is the payment to be made. Without that payment, the countries that are self-financed cannot receive the vaccine, because for them, this is not a donation. COVAX is a platform to have equitable access, to have a better price than the one that can be attained with bilateral agreements. They will be receiving good quality vaccines, because these would be pre-qualified vaccines or vaccines to be used in emergency situation according to WHO. My colleague, Dr. Ugarte, and myself are looking for agreements. We're talking to donors to try to see how we can have Venezuela have access to these vaccines, which would be very important for protection of their population. Thank you. And a final question in connection with vaccines. Several countries in several journalists in several countries, such as journalists from Peru and El Espectador from Uruguay, as well as another journalist from Guatemala, all of them are asking when these vaccines would be reaching their countries through the COVAX facility. Could you please clarify? Thank you. We do not have a final date for any country at this point in time. You need to remember that first the producer needs to have a signed agreement with all of the details, and we already have with some producers, but with others we continue to have a discussion on some details. For example, Pfizer has already placed about 1 million, but for the immediate delivery now in February, we'd like negotiation with the other 39 million doses from Pfizer to be able to provide in the second quarter, that is to say as of April. And we're still pending negotiation with Pfizer. We're also negotiating with AstraZeneca. They have already committed an important number of doses through the facility, but again, we need to finish evaluation with a pre-qualification team from WHO. We think that this will be finalized within the next couple of days. So those are the two conditions with the revolving fund. The revolving fund is in charge of acquiring the vaccines through COVAX for the Americas, and this is very complex logistics. When we are going to work with a country, we need to estimate and give a precise number as to the number of doses, and that number will be guaranteed. And in today's world with flight cancellations and also difficulties from moving supplies from one country to the other, that poses important challenges, and this is very complex, but we are ready. We will be communicating with the countries. The first communication on Friday was to have an estimate for the first half of the year so that they can adjust the plans and also to prepare. Thank you. Thank you very much. And now we are reaching the end of this press briefing. The final questions are related to the variants of the new coronavirus. Several journalists such as Catalina Logo Guerrero from Salud con Lupa and also Carolina Maritz from Brazil. They are asking
about the appearance and spread of new variants of the coronavirus in the region. Are the vaccine going to be effective, and how is the regional genomic surveillance network functioning in the region to monitor emerging variants? Because not all countries have the capacity, funds, and laboratories to sequence the virus. Dr. Etienne?
Thank you for this really important question. There have been 3 new variants of the SARS-CoV-2 virus that have been reported and are causing concerns with regards to the possible increased risk of heightened transmissibility, the risk of increasing the numbers of severe cases, and the diminishing of the protective effect of current vaccines. So we know this commonly as the UK, Brazil, and South African variant because they were first reported from these countries. Variants have thus far been detected in 10 countries of the Americas, but with low frequency. Of course, this might very well change in a few weeks or months. But remember that this is not strange, as mutations are already very common in coronaviruses. And the greater the transmission and the number of cases, the more likely we are to see mutations. So this is why we are pleading with national and local authorities and the general public to intensify efforts to reduce transmission. Now, PAHO is working with countries in the Americas to enhance the ability of the region to detect mutations and new variants. So over many years, PAHO has worked with countries to establish a regional laboratory network for both research and diagnosis of influenza and other respiratory diseases. So building on this network capability, in March 2020, we launched the Regional COVID-19 Genomic Surveillance Network. And this allows the region to detect mutations and variants. 11 countries in the region have this capacity installed, but through the network, other countries can access that service, and we use 2 reference laboratories, one in Fiocruz, Brazil, and the Public Health Institute in Santiago, Chile. PAHO adds supports with capacity building, reagents, and other supplies. With regards to the efficacy of vaccines, as far as new variants are concerned, we must be assured that scientists and epidemiologists across the globe are looking for answers and solutions and studying the situation. And we must be patient, but hopeful. So whether a booster with an original vaccine or a different one is needed, that is under investigation. And we have no doubt that there will be answers shortly. But in the meanwhile, our recommendation to you is to get vaccinated when the vaccine is offered to you. Do not wait. We must also stress that strong preventive public health measures must be continued and enhanced. Authorities must adjust appropriately, but all individuals and families must adopt measures that are aimed at reducing exposure and spread. You need to ensure social distancing. You need to avoid congregating or gathering in groups. You need to wear masks. And we must ensure frequent hand washing and sanitizing. Please, everyone, this is not the time to let our guard down. Let us ensure that we continue to protect ourselves, to protect others, and to reduce the transmission of the COVID-19 in our region. Thank you so much for participating today.
Muchas gracias, doctora Etienne. Ahora sí, entonces hemos...
Thank you very much, Dr. Etienne. Now we have reached the end of this session. Briefly, we will be sending you the remarks by PAHO's director, and we will be publishing that also on our website. Please visit our website, www.paho.org, and you can continue to contact us via email. Thank you very much for being with us today, and we will see you here next Wednesday. Greetings to all.